right, everybody. Let's go to the next lecture, which is incidentally mine. Hi, everybody. My name is Monisha. I'm one of the PGY4s, and hopefully by now you know my name, if not nothing else from the number of emails I send out. I'm going to be giving my senior lecture today. I just need to add a disclaimer that none of the pictures in this presentation are meant to suggest that the person depicted is suffering from any of the aforementioned afflictions. I say this very specifically because my presentation does feature a lot of familiar faces. So yes, this is another wellness talk. Today I'm going to be talking about the pillars of ethics in emergency medicine and how this can lead to moral injury and ultimately burnout. I'll first start by highlighting some questions that we might ask ourselves that result in moral conflict and give some case examples that might or might not be based in true events. As seen in many ethical conundrums throughout history, there's often no right answer. And today, I'm hoping to highlight that fact itself. The fact that there's no right answer leads us to a moral conundrum and can contribute to our unwellness. And as such, I'm not going to be offering any right answers to these cases. We'll go from the cases to a quick intro of bioethics and then talk about wellness, burnout, and moral injury. And lastly, as with any senior lecture, we'll end with a little bit of nostalgia. Starting first with the cases and the questions. To start, I want to highlight a couple of things that we ask ourselves in moments when we feel down, when we have an uncomfortable patient encounter that might lead us to question ourselves as physicians, and as much as being a physician is tied to our identities, ourselves as well. I start out with a question that I find myself asking often: what if I miss something? That's a fear that I have, especially as I look towards becoming an attending in the few short weeks of residency that I have remaining. And it underlies some of the patients that we choose to discharge when we're kind of on the fence about something. A good rule of thumb that I've heard from some attendings is, if it's going to keep you up at night, just order the test. If another physician were in my shoes, would the patient have been better off? This is a tougher question and one born out of self-doubt. While it's important to stay humble in medicine, the moment when you start doubting your abilities is a red flag to check yourself and see how your mental health is doing. Case one to ponder. You have a previously healthy 85-year-old male presenting with head trauma. He has a medical history of AFib, on Xarelto, and well-controlled. He's vaccinated and boosted, goes on daily walks, has 3 children, 4 grandchildren with whom he spends his holidays. He lives largely alone and is able to take care of himself, cooks for himself, gets groceries, handles everything for himself. In the grocery store, he trips over a box in the aisle and comes in with head trauma. You call a trauma code and he has a subdural and a subarachnoid. His mental status deteriorates. You opt to intubate and call respiratory and are told there is 1 vent left in the hospital. Simultaneously, another patient is brought over from the pod. He's a 45-year-old male with hypertension, hyperlipidemia, diabetes, prior CAD with a stent, daily smoker, unvaccinated, admitted the day before for hypoxia secondary to COVID. High flow and BiPAP aren't helping. His chest x-ray looks terrible, and he has deteriorated over his hospital stay. He's in respiratory distress, satting 70s on room air, tachypneic, and is gasping for air. Which patient do you intubate? Case 2 to ruminate upon. You have a 56-year-old male with past medical history of ESRD on dialysis. He has missed 2 dialysis sessions because he wasn't feeling well and went in today. They told him that his fistula was clotted and that he needed to come to the ER. He has no complaints in the ER and just wants his fistula unclogged. He asks that you call the vascular surgeon and consents to an EKG only, but no blood draws. The EKG demonstrates peak T waves and a widened QRS complex compared to his last EKG, which had neither. You discuss with him that you're concerned about his potassium levels and would like to check his labs and place an IV for treatment. He says that he understands and declines all interventions. You say again that you are still trying to reach the vascular surgeon, but in the interim wish to treat. He says he only wants this procedure, does not want to have any medications given, labs drawn, or a shy lead placed. And if we can't reach the surgeon in the next 10 minutes, he'll be sending out against medical advice. What do you do? Does he have the capacity to leave? And lastly, case 3 to consider. One of your colleagues in the department has been going through a tough time at home. They've had some family tragedies recently and they're attempting to get through it. You've been helping them as best that you can, but you're worried that they're not coping well. After missing a couple of sign-outs for them, you notice that they've been missing things and dropping the ball at work. Nurses have come up to you with concerns that because they know that you're friends, ranging from wrong doses of medications to misdiagnoses to getting short with patients and staff. You've tried to address it with them in the past, but they brushed it off each time, saying that they're fine, they don't need you to help. You come across a really bad medical error that occurred as a result, a medication error that resulted in harm. Do you escalate? Do you approach them again? So with those heavy cases in mind, let's jump into a quick intro in ethics, especially in the realm of medicine. There are 4 main pillars of bioethics that I'm sure we all learn in medical school. These underlie a lot of our medical decisions and also form the basis of opinions rendered by hospital ethics committees and by the law. The first is beneficence. This is our concept of doing good, doing what we believe is best for our patient. As a part of this, patients also freely disclose their own personal and medical information to physicians and allow quite a violation of privacy in order to obtain medical care. Part of beneficence also involves respecting the privacy of our patients and the confidentiality of patient information. As a backstory to this picture, Tess, now an alum working in sunny California, made Mark a gold star certificate using a gauze package on an overnight shift for being such a champ on shift, and I thought it personified beneficence perfectly. The second is non-maleficence, also known as primo non nocere, or first do no harm. The concept of straying away from as much harmful diagnostics or treatments for our patients. This is central to maintaining our integrity and as well as the patient's trust. Every diagnostic or treatment that we pursue is fraught with risks, and patients trust us and our medical knowledge to be able to explain this to them and help weigh the risks and benefits in order to give them the optimal treatment. Next is autonomy. Adults and emancipated patients with decision-making capacity have the right to accept or decline offered healthcare. Physicians have the duty to respect this. This is also recognized in the legal doctrine of informed consent. Within this, physicians must inform the patient or guardian with decision-making capacity about the nature of their condition, any treatment alternatives and consequences, and allow them to come to an impartial decision. Within this, it's also our moral and ethical duty to represent ourselves, our abilities, our skill sets correctly, and offer them any alternatives wherever necessary. The fourth pillar is justice. I couldn't find a picture from our class with this, so make of that what you will. The ethical concept of justice implies fair and impartial care with respect to patients' gender, race, age, ability to pay, demeanor, regardless of one's own beliefs. Justice can also be used to signify our duty to equally distribute benefits and burdens within a community. This is the underlying principle in EMTALA, the Emergency Medical Treatment and Labor Act, which is a federal law that requires anyone coming to the emergency department to be stabilized and treated regardless of their insurance status or ability to pay. There are some additional tenets not included in the 4 main principles, but do play a large role in our ethical decision-making, including confidentiality, honesty, distributive justice, and respect for the law. Another ethical foundation that we must come to terms with is called moral pluralism. We have a ton of different sources for ethical guidance, whether this is professional oaths, codes of ethics, cultural values, social norms, religious, philosophical, moral traditions, clinical experience, practical reasoning skills, professional role models, and all of these can come into conflict with one another, and various people might prize one of these sources over another, and in order to come to their own ethical decisions. The issue comes in when trying to reconcile all these various sources. The study of ethics as a whole strives to create this overarching moral theory, which would diminish the conflict and allow for one single resource. Specifically, the goal of bioethics is to be that overarching moral theory. Specifically, emergency medicine physicians encounter unique struggles which cause additional moral conundrums. We're placed into situations that not many other physicians are placed into, which challenges our ethical boundaries. For example, patients often arrive in the emergency department with acute injuries or illnesses that require immediate care. In these emergent situations, we have not a lot of time to gather additional data, consult with others, or deliberate on any kind of alternative treatments. The patients are often unable to participate in decisions regarding their healthcare because of acute changes in mental status or critical illness. And when the patients lack decision-making capacity, we have to step in because we can't secure any sort of informed consent. Additionally, emergency physicians typically have no prior relationship with their patients in the emergency department. Patients often arrive unscheduled, in crisis, and sometimes against their will. Therefore, emergency physicians cannot rely on earned trust or prior knowledge of the patient's conditions or values or wishes with regards to medical treatment. The patient's willingness to seek emergency care and to trust the physician is based on institutional and professional assurances rather than an established personal relationship. And because we are a largely hospital-based practice, we're often governed by hospital institutional policies that we have to adhere to, as well as interprofessional norms of conduct. We play a unique and social and societal role as healthcare providers of last resources when people don't have access to care. And we're also expected to have a broad expertise in a variety of fields and act as a resource for the community. This field includes out-of-hospital care, disaster, toxicology, public health, international wilderness. We participate in a lot of end-of-life decision-making. We encounter a lot of futility. For example, the patients who come in with long downtimes out of the hospital, still in cardiac arrest, we are often the ones that have to pronounce them after ensuring medical futility. And we're often called upon to practice in areas or situations with resource scarcity, especially in light of our own broad expertise. And then the pandemic. It brought its own set of challenges, as Mark talked about earlier. We experienced staffing shortages, made even more in contrast with this change in staffing from FEMA relief. Many of our patients and staff members demonstrated vaccine hesitancy, causing a struggle between our desire to maintain the relationship and our disbelief when people didn't seem to heed the same signs that we were taught. Long wait times for patients as waiting rooms grew, especially as staffing shortages grew as well. Scarce resources, especially at the height of the pandemic, forcing us to choose, at least mentally, who would get the true BiPAP mask and who would get the BiPAP mask attached to the patient with Kerlix and tape. And further, the medical literature and lay press reported widespread feelings of uncertainty and hopelessness. And there was a lack of evidence-based guidelines and lack of familiarity with contingency and crisis standards of care, which eroded confidence in our decision-making, leading to more workplace anxiety and conflict. We experienced social distancing in many ways, lack of human-patient connection, stringent visitor policies, which are still in effect today, and even the physical barriers of PPE. Dr. Wendy Dean, an ER doc who first introduced the concept of moral injury with respect to COVID, said, to do their job, healthcare workers not only dress in personal protective equipment, but also shield themselves with a protective emotional barrier so they can carry on in times of extreme stress. This is similar to soldiers in battle who arm themselves psychologically and try not to think about the carnage and death that's around them. This brings us to our discussion of wellness and moral injury. What is moral injury? It's the psychological distress that results from actions or lack of them that go against one's beliefs or values. It happens when providers are frustrated and can't provide the care that they're trained for, or can't find the solution for the problem that's presented itself. It's described through the witnessing of suffering with little power to help, combined with a system that takes advantage of the patients and those who care for them. It ultimately leads the sufferer to question their own sense of right and wrong. Examples include having to make decisions that affect the survival of others, or where all options will lead to a negative outcome, doing something that goes against your own beliefs, referred to an act of commission, or failing to do something again in line with your beliefs, which is referred to as an act of omission, witnessing or learning about such an act, or experiencing betrayal by trusted others. I view moral injury as part of a continuum, starting with PTSD and leading to burnout. PTSD, or post-traumatic stress disorder, is a mental health condition triggered by a single terrifying event, either experiencing it or witnessing it. It's on the same continuum as moral injury, and it arises from witnessing and participating in events that contradict our own deeply held beliefs and personal code of ethics. It is a single event of moral trauma. It engenders feelings of personal failure, feeling unable to have done enough to right these wrongs. Moral injury comes about from repeated PTSD encounters or moral traumas, resulting in long-standing moral injury. In contrast, it can have effects that outlast other PTSD symptoms, intractable guilt, shame, social withdrawal, and it can be demonstrated by symptoms such as burnout and compassion fatigue. Emergency physicians in particular are a lot more susceptible to burnout compared with physicians in other specialties and other staff within the ER. This might be due to a number of factors, including job strain, fear of making mistakes, sleep disorders, working at night, shift work, and experiencing workplace violence. These problems are not only negatively affect the health of physicians, but are also linked to a higher risk for adverse patient outcomes. As the continuum continues, we see the long-term consequences of physician burnout. We see issues with physician retention, increased stress placed on the staff that do remain. We see an increase in mental health concerns such as depression, anxiety, suicide, which can result in aberrations in patient safety. Long-term physician burnout can also lead to exhaustion and deferred processing of grief and trauma. There's also difficulty that lies in trying to put yourself first. You experience a different sort of moral trauma or moral injury. Believing that putting yourself first and prioritizing your own mental health goes against why we think we become physicians, which is to give back to the patients and to the community. It is also very important to be able to identify when our peers are on the spectrum from the PTSD to burnout. We can see symptoms such as shame, guilt or regret, and stress reactions such as anger, which can ultimately lead to changes in sleep, anxiety, and irritability. Additional signs of burnout include significant and persistent negative changes in behavior or habits, mistakes, isolation, compulsive behavior, and a weakened sense of empathy. So how do we fix this? How do we turn these faces into these faces? It's important for us to feel comfortable asking for help and recognizing those who are in need of help. Asking for help was previously seen as a sign of shame, but we should empower ourselves as a sign of courage that we are asking for help and prioritizing ourselves. How can you help others? Reach out if others show signs of distress, be a good listener, name their feelings. It sounds like you've experienced something that nobody should experience. Can you help me understand how that's impacting you? Be honest. If you can't handle the conversation, point them to someone who can, and try to help people gain a different perspective on how they view themselves, others, and their situations. We can also reaffirm personal and collective beliefs in the purpose of the work of medicine, either with friends or through personal reflections. And yes, for those with a good eye, these two pictures were taken on 2 different days, 2 different seasons, as evidenced by the Christmas tree in the corner of one of them. They're covered up, these 2 are covered up in the same blankets, on the same couch, on the same rug. And if anyone was wondering how the second night ended up like this. Okay, wellness interventions can play a part, though it is limited. Data demonstrates no association in changes to burnout levels, moral injury, compassion fatigue, with increased use of wellness measures and focus on increasing resilience. There are advocates for scheduling according to circadian rhythms, reducing violence in the emergency department, increasing the scope of FMLA, and providing emotional support for physicians who have been sued. As was quoted in one of the articles that I researched, well-being requires more than the absence of distress. It also involves satisfaction across multiple domains of life, such as family, community, spirituality, health, and experiences that stimulate personal and professional growth. Basically, what we're saying is giving us measures just to increase resilience isn't sufficient. We can focus on mitigating PTSD and work on reaffirming our faith in medicine in our work rather than building resilience to bounce back from it. Debriefing can often play a large role in this, reaffirming our knowledge and reaffirming that we're not alone. It's been demonstrated that reflecting on an incident, either with a peer or with a superior or leader, can allow the person to heal and reduce the incidence of long-term moral injury. We can practice our own self-care, including seeking out others to assist in making difficult choices when possible and for support. A bioethicist in the University of Pittsburgh also advocated for shifting away from patient-centered ethics and focusing on public health issues. In doing so, we can broaden an issue and make it no longer about an individual patient. This allows us to change our ethical focus and maintain our sense of right and wrong for overall society. Many also call into play institutional change as a method for helping those who are burnt out or suffering. They advocate for crisis teams in the event of immediate needs of psychological support or structured psychological crisis response teams. They suggest expanded employee assistance programs, monetary or psychiatric, and support teams for whatever method people choose to process their grief and burnout. Many advocate for increased staffing levels as a way to provide support for the hours that have been cut and providers who have been left to carry the brunt of it. There are, of course, more radical solutions for institutional changes that result from changes in public policy and can affect the provider's day-to-day and thus moral injury, compassion fatigue, and burnout. Speakers in the sphere of moral injury have proposed changes including a free market of insurers and providers, thereby releasing the providers from financial obligations. This brings back the focus to compassionate and good quality care and brings medical care back to the bedside where it originally started. Finally, we need to acknowledge that going back on how healthcare was structured before is not an option. We have put our lives on the line to take care of patients. We need our organizations to have our backs now. And now I get to my own personal best solution, combined with some nostalgia. I propose that we surround ourselves with the very best of people to get us through the hard times, whether it's a strong residency, filled with great minds and great thinkers, great friends with interesting interests and hobbies, cute pets, or even cuter babies. In my personal experience, I had the greatest class in the best of times and the worst, from our pre-COVID youth to our post or intra-COVID maturity. Thank you to my residency family and friends, mentors, emotional support program directors, and my patients, all of whom have taught me so much. And with that, that's it. Any questions?